Hello everyone and welcome to our module on the nephritic syndrome. Let's start by reviewing the pathophysiology of the nephritic syndrome. All of the causes of nephritic syndrome, as we will see in this video, lead to inflammation of the glomeruli. That's called nephritis, and that's how the syndrome gets its name, nephritic syndrome. When there is inflammation in the glomeruli, the filtration barrier to red cells and protein is lost. As a result, red cells spill into the urine, and characteristic findings are dysmorphic red blood cells and red blood cell casts. I discussed these findings in more detail in the video on glomerular disease principles. In addition, because the filtration barrier is lost from inflammation, there will be protein in the urine as well. Now, because the glomeruli are inflamed, they're not doing their job, and therefore they are not filtering the plasma, so there's a fall in the glomerular filtration rate. This leads to signs and symptoms of acute renal failure, such as a rise in the BUN and creatinine and a decreased production of urine, which is called oliguria. In addition, because less plasma is being filtered by the glomeruli, there's a rise in the hydrostatic pressure. This leads to hypertension. It also leads to capillary leak and edema, which are hallmarks of the nephritic syndrome. The protein loss in the urine also can lower the plasma oncotic pressure, and that also contributes to the edema as well. So the classic presentation is for a patient to develop dark urine from red cells in the urine, swelling and edema. There are often signs of fatigue. This is due to uremia from the renal failure. And there will be proteinuria, but importantly, the proteinuria is less than 3.5 grams per day. More than 3.5 grams per day is seen in the nephrotic syndrome. In the nephritic syndrome, there is less proteinuria, and that's because the glomeruli are inflamed and there's a fall in the glomerular filtration rate, and therefore less protein is lost in the urine compared with the nephrotic syndrome. Before we get into specific causes of the nephritic syndrome, let me review a very important general point about the site of glomerular injury and how that determines whether a disease process leads to the nephritic or nephrotic syndrome. The major determinant of whether a disease process leads to either the nephritic or nephrotic syndrome is the site of glomerular injury. When the glomerular injury is limited to the podocytes, this leads to protein loss only. That's because the podocytes are walled off from the blood element and inflammation does not occur, and this leads to the nephrotic syndrome, which I talk about in detail in another video. When the site of glomerular injury includes the endothelial or mesangial cells, however, those cells are exposed to blood elements, including inflammatory cells. For this reason, damage to these cells leads to inflammation of the glomeruli, which is nephritis, and that leads to the presence of red cells and protein in the urine. So as we will see in this video, most causes of the nephritic syndrome are related to endothelial or mesangial injury with an influx of inflammatory cells, and this is what differentiates these pathologic processes from the ones that only involve the podocytes and lead to the nephrotic syndrome. Shown on this slide are the major causes of the nephritic syndrome. I'll talk about all of these in this video except for the last one. Membranoproliferative glomerular nephritis is a rare disorder that can lead to either the nephritic or nephrotic syndrome. It tends to be confusing, and I talk about it separately in a short video. All of these other causes we'll go through in this video today, and in general, they all lead to inflammation in the glomeruli, and that's why they cause the nephritic syndrome and not the nephrotic syndrome. Let's start by talking about post-streptococcal glomerulonephritis. This follows a group A beta hemolytic strep infection. Usually it's either impetigo, which is infection of the skin, or pharyngitis, which is infection of the throat. Now, you may be aware that a strep infection can also lead to rheumatic fever. What's interesting is that patients generally do not develop both rheumatic fever and glomerulonephritis. They develop one complication or the other. The reason for this is that certain strep bacteria strains are what's known as nephritogenic. This means they carry a specific subtype of the M protein virulence factor that's known to lead to glomerulonephritis. Other strep bacterial strains are rheumatogenic, meaning that they carry subtypes of the M protein virulence factor that lead to rheumatic fever instead. The pathophysiology of post-streptococcal glomerulonephritis involves immune complex deposition in the kidneys. There is some evidence that circulating antigen-antibody complexes can reach the glomeruli. There's also evidence of in situ formation of immune complexes in the kidneys. But by whatever mechanism, once those complexes reach the glomeruli, they will fix complement and attract neutrophils, and that leads to inflammation. And glomerular inflammation leads to the nephritic syndrome. Importantly, the inflammation will deplete plasma complement levels, so hypocomplementemia can be seen when you test the plasma of patients with post-streptococcal glomerulonephritis. This is also seen in other forms of nephritis, including lupus nephritis and MPGN. Post-streptococcal GN is common in children, although it can also occur in adults. The classic case you should know for your board exams is a child 2 to 3 weeks following a strep throat infection who develops the nephritic syndrome. The reason it takes 2 to 3 weeks to develop is because it takes time for those immune complexes to form and build up in the kidneys. On light microscopy, the glomeruli are enlarged and hypercellular. The hypercellularity is related to inflammation. It's seen in many forms of glomerulonephritis. The antibodies build up in the subendothelial layer of the glomerular capillaries, and for this reason, you will see a granular appearance if you do immunofluorescent staining, especially for IgG and C3. Shown on the screen is an example of a granular appearing immunofluorescent staining of a kidney biopsy sample. If you focus on the left side of the screen, you see a bumpy appearance to the bright green area. That bumpy appearance is because of deposition of antigen-antibody complexes in the kidney. The hallmark of post-streptococcal glomerulonephritis on electron microscopy is the presence of subepithelial humps. These are immune complexes that have worked their way into the subepithelial layer, and they formed characteristic humps, as I've shown on the screen. This finding is virtually diagnostic for post-streptococcal GN, and you want to make sure you can recognize it for your board exams. Age is a very important prognostic factor for post-streptococcal GN. This disorder has a good prognosis in children. 95% completely recover. Adults have a worse prognosis. Only about 60% recover. Many develop renal insufficiency, and this can even occur late, 10 to 40 years after the initial illness. In addition, some adults go on to develop rapidly progressive glomerulonephritis, which we'll talk about in a few slides. Therapy for this disorder is supportive, meaning there's no specific therapy, and for those patients that recover, spontaneous resolution occurs over time. Our next cause of the nephritic syndrome is IgA nephropathy, which is also called Berger's disease. This is the most common form of glomerulonephritis worldwide. It typically presents with repeated episodes of hematuria due to the nephritic syndrome, and over time, it leads to end-stage renal disease and hemodialysis in about half of patients. The underlying problem in IgA nephropathy is an overactive immune system. Patients with this disorder have increased IgA synthesis in response to immunologic triggers. Remember, IgA is the mucosal antibody, so when infections of the mucosa occur, like respiratory infections or GI infections, this leads to increased IgA synthesis in patients who have this disorder. That in turn leads to IgA immune complexes which deposit in the mesangium. And remember what we said at the beginning of this video. Disease processes that involve the mesangium will trigger inflammation in the glomeruli. That leads to nephritis and the nephritic syndrome. Now what's interesting is you may know from immunology that IgA usually does not activate complement. However, in this disorder, the IgA immune complexes do lead to the activation of complement via the alternative and lectin pathways. However, the activation is relatively weak, and you do not see hypocomplementemia in this disorder like you do in post-streptococcal glomerulonephritis. The end result, however, is that glomerular injury and inflammation occurs, and that leads to the nephritic syndrome. Just like in post-streptococcal glomerulonephritis, we have a granular immunofluorescent staining pattern in this disorder. What's different, however, is that if you want to see the granular pattern, you must stain for IgA. In post-streptococcal glomerulonephritis, we stained for IgG and C3, and we saw a granular appearance. In this disorder, you must stain for IgA to see the granular immunofluorescence. The classic case of IgA nephropathy you should know for your board exams is a patient with recurrent episodes of hematuria since childhood, and the episodes follow either an upper respiratory infection or a diarrhea illness. There is slowly worsening renal function, meaning a rise in the BUN and creatinine over time, and possible progression to end-stage renal disease or hemodialysis, although this takes more than 20 years to occur. And it's very important that you don't confuse IgA nephropathy with other glomerular disorders. Specifically, post-streptococcal GN can also follow an upper respiratory infection. However, that takes weeks to occur following the infection. IgA nephropathy occurs days after infection. You also don't want to confuse IgA nephropathy with minimal change disease. Minimal change disease can follow an upper respiratory infection. However, minimal change leads to the nephrotic syndrome and not the nephritic syndrome. In the vasculitis video in the immunology section, I talk about a disorder called Hinock-Schönlein purpura. You should be aware that this disorder is IgA nephropathy plus extrarenal involvement. HSP is the most common childhood systemic vasculitis. It presents with IgA nephropathy plus extrarenal involvement. So for example, children with HSP often have involvement of the skin. They have palpable purpura on their buttocks and legs. They often have involvement of the GI tract with abdominal pain and melena. They can also have joint pains from IgA deposition in the joints. But the problem is the same as in IgA nephropathy. It's diffuse IgA deposition leading to the vasculitis symptoms. And when you do a tissue biopsy, either of the kidneys or any involved organ in HSP, you will see IgA, just like you can see in kidney biopsy samples of patients with IgA nephropathy. Our next cause of the nephritic syndrome is diffuse proliferative glomerulonephritis. This is seen in patients who have lupus. This is the most common subtype of lupus renal disease. It's called type 4 lupus nephritis. And in terms of recognizing this in a board question, you should be aware that it will often present with other features of lupus like fever, rash, or arthritis. Just like in post-streptococcal glomerulonephritis, the problem in diffuse proliferative glomerulonephritis is immune complex deposition in the glomeruli. The immune complexes lead to an inflammatory response that leads to nephritis and the nephritic syndrome. The renal disease that occurs in lupus is a massive topic, but I will briefly review it here to help you better understand how lupus can lead to the nephritic syndrome. There are 5 subtypes of lupus nephritis. Type 1 and type 2 are mild forms of the disorder. Type 3, 4, and 5 are the more serious forms of lupus nephritis. Now, type 5 lupus nephritis is unique in that it leads to the nephrotic syndrome. I actually talk about this in the video on nephrotic syndrome. I talk about how membranous nephropathy is a cause of the nephrotic syndrome, and it can occur in patients with lupus. When it does, that's called type 5 lupus nephritis. Type 3 and type 4 lupus nephritis are the same disorder. They're distinguished based on how many of the glomeruli are involved. If less than 50% of the glomeruli are involved, lupus nephritis is called focal proliferative nephritis. That's type 3 lupus nephritis. If more than 50% of the glomeruli are involved, the lupus nephritis is called diffuse proliferative glomerulonephritis. That's type 4 lupus nephritis. That's what we're talking about in this video now. It's the most common form of renal disease among patients with lupus, and it leads to the nephritic syndrome. So as I just mentioned, the word diffuse is in the name of the disorder because more than 50% of the glomeruli are affected. If less than 50% are affected, it's called focal. And the word proliferative is in the name because there is increased cellularity of the glomeruli. There is an increase in the number of mesangial cells, endothelial cells. There's also monocyte and neutrophil infiltration as a result of inflammation. Subendothelial deposits of immune complexes are what drive the immune response. And like I talked about in the beginning of this video, disease processes that lead to the nephritic syndrome tend to involve the endothelial layer. So it should make sense to you that subendothelial immune complex deposits are seen in this disorder that leads to the nephritic syndrome. The immune complexes come from anti-double-stranded DNA antibodies and other antibodies that are associated with lupus, and the inflammation can deplete peripheral complement levels and lead to hypocomplementemia, which you can also see, as I mentioned before, in post-streptococcal GN and also in MPGN. The classic finding on light microscopy is the presence of thickened capillary loops. This is called wire looping. This is an example of it shown on the screen here. You can see that these capillary loops are dark purple and thickened compared to normal. Just like we have seen in other causes of nephritic syndrome that involve antibodies and immune complexes, there is a granular appearance on immunofluorescent staining in diffuse proliferative glomerulonephritis. Lupus is famous for causing what's known as the full house pattern of immunofluorescent staining. This means that you can see this granular pattern when you stain for IgA, IgG, IgM, C3, or C1q. All of these things are found in the diffuse inflammation that's occurring in this disorder in lupus patients. You will read in board review books that diffuse proliferative glomerulonephritis can present as either the nephritic or nephrotic syndrome. The reason for this is because in clinical practice, this disorder has a mixed presentation. There's some element of proteinuria, hematuria, and reduced GFR, and sometimes the proteinuria reaches the nephrotic range, and for this reason, you will see it stated that DPGN can present as either the nephritic or nephrotic syndromes. This is the most severe form of lupus nephritis. It's the worst form to have. It has the worst prognosis, and it often leads to end-stage renal disease and hemodialysis. Our next cause of the nephritic syndrome is RPGN, which is rapidly progressive glomerulonephritis. This is also called crescentic glomerulonephritis, and it gets this name because the hallmark on renal biopsy is the presence of crescents within the glomeruli. I'm drawing my pen through a crescent in one of the glomeruli in this image. There's another one over here. These crescents are the hallmark of RPGN. Now, RPGN is really a pathologic description. It's not a cause of the nephritic syndrome. There are many diseases that lead to this pattern on renal biopsy and cause this condition. The crescents seen on biopsy are formed by inflammation. You can find within them monocytes and macrophages and fibrin and other inflammatory elements. What RPGN really represents is a common pattern of inflammation in the glomeruli that results from many different diseases. However, once this pattern occurs, it is rapidly progressive. The crescents form quickly, the kidneys shut down, and this can very rapidly lead to severe renal failure. So I've summarized these points on this slide. RPGN is a severe form of glomerulonephritis. In other words, a severe form of inflammation in the kidneys. It results in progressive loss of renal function. The onset is rapid, and it often presents as acute renal failure with generalized symptoms of renal failure like fatigue and anorexia. So I've seen a number of patients with this disorder in my career. As I said before, they usually present with generalized symptoms from renal failure like fatigue and anorexia. Blood work shows elevated BUN and creatinine indicating acute renal failure, and when you examine the urine, you see evidence of nephritis, including red blood cell cast. This usually leads to a renal biopsy, and when you examine the renal biopsy tissue under the light microscope, you see crescents. Once you see the crescents, you know that you're dealing with a case of RPGN, but you don't know what is causing it. As we'll talk about in the next few slides, there are multiple disorders that potentially lead to this pattern of inflammation and this type of presentation. There are a number of ways to categorize the causes of RPGN, but one that is commonly used is to distinguish the different causes based on the pattern of immunofluorescence. Type 1 RPGN is RPGN that has linear immunofluorescence staining, type 2 has granular immunofluorescence staining, and type 3 has negative immunofluorescence staining. Let's talk about type 1 first. This form of RPGN is the result of anti-glomerular basement membrane antibodies, or anti-GBM antibodies. This is an autoimmune process where antibodies are produced against basement membrane antigens due to an unknown stimulus. There's an important tie-in with immunology here. Because this process involves antibodies against tissue antigens, this is an example of a type 2 hypersensitivity reaction. When you perform immunofluorescence staining in this type of RPGN, you see a linear pattern, not the granular pattern we described before for immune complexes. When you do immunofluorescence staining for IgG antibodies, it will look like what I've shown on the screen here. This is a linear pattern, very different from that lumpy, bumpy pattern that we saw when there was immune complex deposition. That is the granular pattern. Type 1 RPGN can be seen in the setting of a disorder known as Goodpasture syndrome. This is a disorder where antibodies are produced to collagen, specifically to the alpha-3 chain of type 4 collagen. This chain and this type of collagen can be found in the glomerular basement membrane and also in the alveoli. For this reason, hemoptysis and nephritic syndrome both occur in patients with Goodpasture syndrome. So the classic case is a young adult male, which is the most common demographic, who presents with hemoptysis and hematuria. That person has antibodies to the alpha-3 chain of type 4 collagen, and that person has the Goodpasture syndrome. Now we'll talk about type 2. This form of RPGN is caused by immune complex deposition. For that reason, this is a type 3 hypersensitivity reaction, not a type 2 like we talked about in RPGN type 1. Also, because immune complexes are involved, it gives a granular pattern of immunofluorescence as shown on the screen here. Hopefully you can appreciate that this looks very different from the linear pattern we saw 2 slides ago. This granular pattern is the result of immune complex deposition in the kidneys, which can lead to type 2 RPGN. This form of RPGN commonly results from immune complex kidney disorders that we have already discussed in this module. For example, patients with post-streptococcal glomerulonephritis can progress to develop crescents in the kidneys and RPGN. And in fact, this is the most common cause of RPGN, progression of post-streptococcal glomerulonephritis. RPGN type 2 can also result from lupus. Diffuse proliferative glomerulonephritis, which we discussed earlier, can progress to the development of crescents in the kidneys, and that will lead to RPGN type 2. Type 3 RPGN has negative immunofluorescence staining. This means there is no immunofluorescence when you stain for IgG, IgA, or other components of immune complexes. It's called pauci-immune because there is a paucity of immune complexes seen on immunofluorescence staining. This is a picture of what it can look like on the screen. You can see that the glomerulus in the middle of the picture is dark because nothing is lighting up. Most patients who have this type of RPGN are ANCA positive, meaning they have either the C-ANCA or the P-ANCA antibodies. I talk about these antibodies in detail in the video on vasculitis. They are commonly seen in many vasculitis syndromes, and in fact, most patients who have RPGN type 3 also have some other vasculitis syndrome. ANCA stands for anti-neutrophil cytoplasmic antibodies, and there are a number of vasculitis syndromes that involve these antibodies. I discussed them all in the video on vasculitis. These include Wegener's granulomatosis, which has C-ANCA antibodies, microscopic polyangiitis, which has P-ANCA antibodies, and the Sturge-Strauss syndrome, which has P-ANCA antibodies. All of these vasculitis syndromes can lead to RPGN, and when they do, they lead to a pauci-immune finding on immunofluorescence staining. So here's a picture showing how you can keep the causes of RPGN organized in your mind. It presents as we discussed before, and a renal biopsy will show evidence of crescents. Type 1 RPGN involves anti-glomerular basement membrane antibodies, and it has linear immunofluorescent staining. Type 2 involves immune complexes. It will have granular staining. It's often a progression of post-streptococcal disease or lupus nephritis. And then type 3 is usually caused by a vasculitis syndrome. It has pauci immune immunofluorescent staining. Most patients with that form of RPGN are ANCA positive. Our final cause of the nephritic syndrome is very rare. It's called Alport syndrome. It's also called hereditary nephritis. This is a genetic disorder that involves a type 4 collagen defect. Children born with this condition have genetic mutations in the genes that code for the alpha 3, alpha 4, or alpha 5 chains of type 4 collagen. And those chains are found in the basement membranes of the kidney, but also in the eyes and in the ear. For this reason, children with Alport syndrome have a classic triad of hematuria from nephritis, as well as hearing loss and ocular disturbances. These are X-linked disorders, so they more commonly occur in boys, and the way you want to recognize these in a board question is by looking for a male child who has this triad of symptoms and a family history of these types of problems. The question will likely ask you about the type 4 collagen involvement and the alpha chains. And that concludes our module on nephritic syndrome.